This is a short video on how to correctly undertake an ABCDE assessment on a deteriorating patient, and then using S-bar, formulate a handover. Remember, if your patient's condition is deteriorating, undertake a full set of observations and inform the nurse in charge of your concerns immediately in accordance with the Early Warning Score Action Plan. Please remember, when carrying out an A to E assessment, to respect a patient's dignity and not to expose them unduly. On approaching the patient, adopt the look, listen and feel approach. Look at their position in bed. Do they look comfortable? Are they slumped or laid flat? What is their colour like? Are they pale, cyanosed, flushed? Is their breathing noisy or quiet?
Morning, Mr. Matthews. I'm one of the outreach team, just come to see how you are.
As you reach the patient, touch them and call their name. Do they feel hot, cold or clammy? And are they responsive? If not, do you want to call for help now?
Hello, good morning. I'm not feeling very well.
Oh, just give me a few minutes and I'll have a quick look at you.
All right.
A is for airway. Always start your A to E assessment with the airway, as a partially or totally obstructed airway will lead to a rapid deterioration of your patient. Never move on to B until you are happy the airway is patent. If an airway is partially or totally obstructed, call for help and think about manoeuvres you can adopt, including head tilt chin lift, jaw thrust, recovery position. Equipment you will need includes airway adjuncts and suction. When a patient's airway is compromised, remember to start high concentration oxygen, 12 to 15 litres per minute via a non-rebreathe mask. B is for breathing. One of the earliest signs in the deteriorating patient is the respiratory rate. The respiratory rate should be taken for a full minute, and you should note not only the rate, but if it is regular or there are periods of apnea or chain stoking. Try not to let the patient know you are counting their respiratory rate, as this may make them breathe faster or slower. Pretending to take a pulse is a good tip, as if the patient thinks you are counting their pulse, they will tend not to talk to you, and so you can record an accurate respiratory rate. Whilst counting the rate, look to see how comfortable the patient is with his or her breathing. Are they using accessory muscles? Do they look like they've just run up 10 flights of stairs? Are they mouth breathing? This could be a sign that their oxygen levels are low. Make a note of the patient's colour. Are they centrally cyanosed? Are their lips or mucous membranes blue tinged? In dark skinned patients, cyanosis may present as a grey or whitish tinge.
Okay.
Remember to record the respiratory rate that you have taken.
I'm just going to put this little button on your finger, sir, and then I'll have a quick listen to your breathing.
Pulse oximetry is a simple, relatively cheap and non-invasive technique to monitor oxygenation. Remember that pulse oximetry takes a minute or two to settle down and record accurately. At this time, record the percentage or flow of oxygen the patient is receiving. It is a good idea to check the flow rate yourself and not just copy what's been written down before. If you feel comfortable, undertake a more thorough chest examination, including palpation and auscultation. At this point, consider any actions you need to take to improve B. For instance, sit the patient up in bed or even out of bed. Start increasing the oxygen within guidelines, humidifying the oxygen, chest physio, giving a prescribed nebulizer, collecting a sputum sample, undertaking suction, salt assessment, passing an NG tube, or making the patient nil by mouth.
Okay. I'm just going to put you a little bit of oxygen on.
Okay.
just pop that around the back of your head. I'll just check your pulse a moment.
Circulation. Check the patient's pulse for a full minute. Do not rely on the pulse displayed on your Dynamap. Feel the radial pulse first, because if the patient has a radial pulse, they should have a systolic blood pressure higher than about 80 millimetres of mercury. If a radial pulse cannot be felt, try the brachial or carotid. Bearing in mind that if you need to check these pulses, your patient's blood pressure could be extremely low. Do you want to call for help now? If the pulse is fast or irregular, consider a 12-lead ECG. When checking the pulse, note if the rate is fast or slow, regular or irregular, weak or strong. Also note if the patient is warm, cold, clammy, or sweaty.
Thank you.
Document your findings on the observation chart, taking care to record a graphical representation as well as a number.
And I'm just going to check your blood pressure, sir.
Record the blood pressure with Dynamap, or manually if unrecordable with the Dynamap, making sure to use the correct cuff size. Again, document your findings on the observation chart, taking care to record a graphical representation as well as a number. If you are worried about low blood pressure, check capillary refill. Apply digital pressure for 5 seconds on a central part of the body, such as the sternum, then release pressure. The skin should return to its original colour in 2 to 3 seconds. Any longer is abnormal and may suggest hypovolemia. A reliable indicator of adequate blood pressure is urine output. Check fluid balance and consider catheterisation and hourly urine measurements. At this point, consider any actions you need to take to improve C. For example, encourage oral fluids. Does the patient need cannulating? Review IV fluid regimes. Consider urinary catheter, strict fluid balance, monitor other losses such as nasogastric or from drains. 12-lead ECG, blood specimens, blood cultures. D is for disability. Check and record the AVPU score. Also check blood sugar, as a high or a low blood sugar may affect conscious level.
We're just going to check your blood sugar. A little stab on your finger there.
If the patient is scoring anything other than an A on AVPU, consider undertaking Glasgow Coma score. If you are recording a GCS, then don't forget to check pupillary reaction. At this point, consider any actions you need to take to improve D. Treat abnormal BMs. Recovery position if AVPU is P or U. Start or increasing oxygen within guidelines. Commence neurological observations. E is for exposure. Now you are coming to the end of the A to E assessment. It is important to look for other clues. Whilst maintaining the patient's dignity, examine the patient. Check and record the patient's temperature. Record the patient's pain, nausea or sedation scores if appropriate. Check the patient's skin for signs of rashes or sores. Check wounds or drains and stomas if not already done so. Examine calves for signs of DVT and check prescribed Clexane. At this point, consider any actions you need to take to improve E. Remove excess clothing if pyraxial. Use a fan or an open window. Give prescribed paracetamol. Give prescribed analgesia. Take samples for culture and sensitivity of drains and wounds if appropriate. What to do next? Now you have completed your A to E assessment, you need to document your findings and actions. Follow the early warning score action plan and repeat the patient's observations following your interventions and document your findings. Before calling the doctor or outreach, think about how you are going to collect the information you need. Use SBAR, which is Situation, Background, Assessment and Recommendation, to ensure all information is given in an ordered and concise fashion. Does your ward have SBAR forms? Do you need to obtain some?